Okay, thank you very much, Thorvaldur and Stefan, for this nice short lecture. Um, Now it's time for Q&A. You are more than welcome to introduce your questions in the chat. But if you don't mind, I'm gonna break the ice, making just one question. Meanwhile, you can think about your own questions, and you can you can have time to write them down. So uh, after having listened to you, I am mainly thinking about the following question. I'm also treating patients. I do research on pain and treat patients, and I feel very related to the reality you have presented now. And my question is, what tips can you both give to the audience regarding how to balance patient expectancies regarding the treatment that they should receive, and evidence-based treatments or guidelines, recommended treatments, and also how to assess this? Because you have mentioned some testimonials of certain patients saying, for example, I didn't know this. If I had known that, it would have been different, no? So one conclusion that I get out of your lecture is that we as physios should not, or as a clinician, should not assume what the patient is thinking, no? So my question is how to assess the reality of the patient in order to better adapt to him or to her and balance evidence-based treatment and patient expectancies.
Oh, it's quite a few questions in one there.
It wasn't going to be easy.
If I may start, I think that the main thing is asking the patient what they're expecting to get from you, because then you could at least address it in the beginning. If they have an expectancy of a lot of, let's say, passive modalities because that's what they have gotten previously, then perhaps you should try and address it. And one of the ways to do that is to get them to reflect of what have they gained by this modality in the past. So if they have a history, let's say 5 years of pain, and they said this treatment works for me, the question could be, if you've had this treatment, it should be top of the line. Why do you think your pain continues to linger on? Like, that could be a good opening to get them to reflect on, perhaps it's time to try something else. And a way to also reassure them so they don't feel they're abandoning everything is to say something along the lines that, let's try something new, but if it doesn't work for you, you always have what you've tried previously with others that you can fall back on. So it's not like they're completely jumping into something new without the possibility of going back to what they have preferred earlier, but giving them an option. And I think the most important thing is getting them to reflect what have they gained from what they've done so far. If you can get that reflection, you can go a long way with talking to them and base it on the available recommendations.
Yeah, I would support that, and just to add a bit on to that, I think it's extremely important to that we are mindful of the fact that sometimes we healthcare professionals can be we can sort of place ourselves in the way of recovery, because very often, well, if we take acute pain, for most people it would have a really favorable outcome. So the likelihood of you recovering without me intervening is good. So what can I do to facilitate that? And for most people, this would require advice on what type of activities can you undertake now when you're in the recovery phase. But of course, some people develop chronic pain. Stefan had a few examples of those where spontaneous recovery is apparently not going to occur. And I would also second what Stefan said with regards to, well, if you've had passive treatment on multiple occasions in the past, what's the likelihood of me having some magic powers of being able to get it right this time. And I think also just to provide evidence-based care, I think it's very important for us who are trained in manual therapy. Well, I did a massive training in manual therapy, not to say that I'm a world champion in it, but I became quite good at it. But I think the biggest value for me in my clinical practice is trying to figure out, well, when is it appropriate to choose manual therapy? And for me, with my patient cohorts, it's just something that's almost disappearing from my clinical practice, because it is valuable for some, but the effects are short term, and the effect sizes are very small if we look at the research.
And I think to follow up on that, like there's nothing wrong with using manual therapy as part of a session, but if you continue to do the same approach and it's not giving you any effect, then probably not the right thing. So for many of the patients that we've seen that have tried this approach for a long time, and some for years even, that obviously is not going to be what's going to make the big difference. And I think this getting them to reflect on this and may help making the more active approach more appealing.
Yeah, and part of what you have said connects to one question from Roberto, who asked about the management of the acute phase. Do you think that there are fundamental differences between the principles we use with chronic pain patients, and acute pain patients, or it's fundamentally the same? There are big differences regarding how to introduce these principles of self-management, etc.
Do you want me to take this one?
Yeah, you can
Well, I think it's first of all a brilliant question, and in an effort to try to answer it, then I would say, well, often there would be differences, because if there's an acute onset, we can take an acute sprain in the back or neck pain after a whiplash in a car accident or something along those lines. The chances of there being tissue damage present is relatively high. And for most people, so the visual aspect of things is very often important for people to be able to visualize and relate to something. And people relate very well to sprains they have in other parts of the body. So if, for example, the ankle or the finger or something, if they hit their thumb with a hammer, you can see swelling, you can feel something that is probably signs of an acute inflammation. Now, acute inflammation very often follows, a certain timeline. This has been demonstrated many times in animal models. So even if you do nothing, you're probably going to get better. But promoting the recovery would probably be the way to go. So finding positions and way to move around that do not provoke pain, in these cases, it is actually quite valuable that the patient has pain, because you get very clear indications of what maybe to avoid and what to engage in. And the main message would probably be stay active in as active as possible, and this applies for almost all acute pain.
Very good. There's one question, or actually two questions from Carlos, who says that it's been mentioned. I'm going to summarize the question because it is a bit long, but I hope I get the point. It's been said that there's no big difference between delivering treatment or information through digital media and face-to-face, no? But he says, what kind of digital media? Because he believes that perhaps just providing a link to a video to the patients might not be as effective as face-to-face interaction. So are we talking about digital media in general, or some specific digital media?
Yeah. Do you want me to take this one?
I'm happy to answer.
Yeah, go for it.
Yeah. So it's very individual what is needed, at least from the patient that I see in a clinical setting. Some would definitely need a follow-up because I know they would have a lot of questions and maybe they don't feel as confident using a digital media like an online consultation, etc. So I'm happy to tailor it to what the individual wants. But I also have some patients that just want to send me an email, tell me, I feel this, I've done this, it's going okay. Should I continue or should I increase or progress my program? And then I think that would be overkill to call that patient in just so I can have a face-to-face time rather than just answering the email and saying, yes, everything is going according to plan. So I think, again, it really comes down to what is the individual needs and what do they want. And the best way to figure that out is simply to ask. So at the end of a session, if I think we could probably do without a specific follow-up, but just an email, I may suggest this and I will listen to the response. And some patient will say, no, I would actually prefer if we put a time in so I can come here if I need, and I can always postpone it if I don't. And others say, yeah, I'll just send you an email and then we can figure it out from there. So I really try and tailor it to what is it the individual need.
Mm-hmm. Yeah, and to follow up on the question regarding referring to a video online or something that's sort of generic information, most people would prefer getting advice that specifically addresses their problem. So like low back pain it's not a uniform entity. So it comes in all shapes and forms. There can be very many individual factors like what provokes it, how intense it is, what can alleviate the pain, etc. And for many people, getting generic information would not be satisfying enough. And this is actually one of the points I had in terms of if we want to use digital media, can we in any way create that media so that it accommodates individual needs? So I'm physio by background. I have no idea how to create algorithms. I have no idea how to use, create or use big data to sort of vacuum clean everything that exists about clinical trajectories to find, based on your individual presentation, you should do this, or this. But this is probably the direction we're headed in. So, and healthcare professionals will definitely need to collaborate with people that have these competencies in the future.
Maybe one conclusion we can get out of what you both have said is that if we assume that the patient can have access to digital media and can deal well with it, it doesn't matter the media as long as the patient perceives the information relevant and specific and individualized. No, what people perhaps don't want is to receive just generic information, regardless it is face to face or with digital methods.
Exactly.
And I think one of the points that both Toldo and I have touched down on, like, I think a lot of it is about reassurance that everything is okay, it's going in the right direction. I really think that's a key. And also, of course, if it's not, that you can then help them out and try and change the trajectory to what you want. But this reassurance that everything is going according to plan. So a good thing is also telling the patient that have come to you, what do you expect them to experience over what period? So if you can kind of set up, this would be okay, but this is not. It's okay to have a little bit of pain after you've done your exercise. But if it lingers on with a massive flare up that keeps on for days every time you've done this exercise, then perhaps we need to change it. So give them a set of parameters of what is okay and what isn't. That would be helpful, at least to most. And they'll feel secure in doing that.
You have, Stefan, already partially answered the other question. We're getting more questions. I hope that you have still a few minutes, until 8 will be like 8 minutes, but it's good that we have more questions. The other question is, well, given that different exercise types or dosages doesn't seem to have a very different effects. How do you assess, monitor, or decide the exercise dose that your patient is doing? Perhaps assume that in part assessing the expectancies, no, and the patient history, etc. But can you elaborate a bit more on this?
Do you want me to take that?
Yeah, go for it.
Yeah. So it depends on some of the things that Tordo was also mentioning. What is it you want to do with that exercise? Like, what is the goal? So is the goal, like if it was, let's say, a whiplash patient, is the goal just to get them moving right now, then find something that does not cause pain would probably be smart if you want them to feel safe and start moving the neck more. Whereas if you want to push on and get them stronger, because you've found that that is what you need for that individual patient, then perhaps it's okay that they feel pain as long as it doesn't linger on for many hours or days afterwards. So it really depends on what is it you want that exercise to do. Is it to get stronger? Is it to get endurance? Is it just to get them moving? And then, of course, again, tailor it to the individual. What are they okay with? Because some patients, and they're sometimes the hardest to manage, are the ones that don't mind the pain. So they will just take anything to the extreme. There, you maybe need to hold them a bit back if you can see that they're continuing to get more sensitive over time. Whereas others may just need that specific approach. Just go on, do whatever you want, get back into it. If you feel anything, do this. So reassure them that all the tools and things that they've already learned, the things that they've already gotten, will also work the next time they feel a flare up. So they feel they have some competencies. I think that's very important, that they're not relying solely on us to help them every time something happens, that they get some competencies to address this on their own. And of course, we should be there to support them when they need.
Oh, very good. I think we have time for just a couple of questions more, which is aligned with what we are discussing. Sarah, who was active in previous webinars, is asking which self-management strategies have some most consistent evidence for improving persistent pain, and if there are some patient populations in which these strategies are more effective, because he or she, I'm sorry, I don't know you, but has said that he has been working with patients with persistent neck pain, but Sarah finds a bit difficult and challenging for patients to adhere to these self-management strategies. So there are some that are more effective to others, and if there are some populations in which self-management strategies have some more effectiveness.
Yeah. Yeah, I think these are valuable reflections, and if I knew the answers to all of them, I would be sitting on a pot of gold, I assume. But I completely relate to what she's saying, and I think relating to her finding it difficult to use self-management strategies in people with chronic neck pain, I can only say that, well, she is definitely not alone. And I definitely do hope that I did not come across as somebody saying it's easy, just do this and then everything is good. But the things to probably consider in terms of designing a self-management strategy for, let's say, her neck pain patients. Going back to how do we define self-management? Something that's empowering, that sort of goes without saying. It's an active approach, but I think the key is here probably the collaborative element in it, because we can, as health professionals, we are a bit biased because we know pain stuff, and we know how biomechanics work. We know a lot of stuff that the patients do not know. But it's our job to educate the patients so they at least come up to so they get user proficiency in understanding how pain works, etc. Now, exercise would be one approach, but here again, like Stefan was saying in his talk, it is absolutely crucial that, well, we have to choose exercises or activities that are meaningful to the patient. So if it's the gym, Stefan sends his patients to, but this person hates going to the gym, then it's probably not going to work. And for the next patient in line, it might be completely opposite. And the dosage and the volume and the resistance and amount of repetitions, this is where it becomes sort of like Stefan was saying, well, what do we want to get out of it? Do we want to build resilience? Do we want to build security, getting them to feel confident with moving the neck or arm? I think that should be sort of prioritized instead of looking at strength.
Yeah, and I think to follow up on that, having that discussion with the patient, what it is they want and what they can realistically get done in their normal day, like what can they fit in? Because one of the things I see for a lot of the patients that we see in our clinic is they come and they have had like tons of programs, very long, very, very extensive and very good programs. They've just never done them. Or they've done them once or twice and then, oh, it takes too long. I can't manage it because I also need to manage my kids and I need to go to work and all of these things. So maybe doing 45 minutes of exercise on a daily basis isn't an option. Mm-hmm. So instead, and that's where some of the work that Professor Pálsson and Assoc has done is very good, because it's shown that even a few minutes a day can make a difference. So it doesn't need to be big. But again, you need to figure out if it's strength, then you need to go pretty heavy on the load for those minutes. Mm-hmm. If it's just getting them moving, then doing anything that doesn't hurt would probably be fine.
Yeah, let me to also introduce here my experience. This is a very good point, because I have also experienced many times with patients that perhaps they might have the assumption that adhering to an exercise program or self-management program is doing something very, very specific for a very long period of time, and they have never previously exercised, no? So they feel succeeding like very far away from them. But when you just say that perhaps doing 3 minutes of exercise twice a day, when they just have a break, is very, very good. I have personally found success with some of these patients. Many of them think that 3 minutes of exercise is absolutely useless. But when you explain to them that they might have benefits out of it, they say, okay.
And some of these, to follow up on that, Victor, is like some of these are the ones that come back and then, oh, I would actually like some more now. I felt how it's helping me. Can you give me something extra? Like those are the ones that you may have sent home with this. It's been fine. A few months later, they'll write to you again. This is going really well, but I'm getting bored of this exercise. Can I do something more? And like you just need to tap into this. They're already on a very good trajectory. They're doing fine. And it doesn't need to be like a whole lot of sessions. They may need to just come in for a single session. You give them something new and they're quite happy to move on their own.
Yeah. And maybe one or two more very tiny questions that I think they're very interesting. One is, what indicators do you use to say that a self-management strategy is succeeding in a patient? Do you focus more on pain reduction or less disability or patient satisfaction? It's one question from my very good friend from Uruguay, Rodrigo. What do you normally use to say that self-management strategy is succeeding? What indicator?
I think, again, it depends on the context you put it in. So if you have somebody who's had chronic pain for a long time, focusing on pain may not be the smartest thing. It may be focusing what can they do with this pain. So usually when people come, it's because there's something they would like to do that they can no longer do due to pain. And it's quite seldom that I have patients coming in saying, I would like you to get rid of this pain because it hurts. They come because they can't do what it is they want to do. So quite often I focus on, so with this, what is it you would like to be able to that you cannot do now? What is it you want me to help you to be able to do? And I think that's probably like involve and engage the patient in this discussion is one of the important things if you want to make sure that your goals are aligned.
Yeah. And just to follow up on that, because I fully second that, especially in chronic pain. In acute pain, it might be very different. But in chronic pain, you would very often, like Stefan was saying, you would want the patients are there because there are things they cannot do anymore. And getting them to focus on pain with pain being the outcome, you're pretty much setting them up to focus on the very thing you want them to feel less. So it's sort of like not thinking about a blue elephant. Sort of your mind, of course, goes, towards scanning your body. How am I doing? And the pain's still there. So it's often it's a self-fulfilling prophecy almost if that would be the main outcome in chronic pain.
And the very, very last question from Peter: do you think that exercise should always be a part of the self-management interventions, or it might be left out in certain patients?
We tried at least to give some of the answer to that in our talk. So getting people moving and being active is probably more important than them to do any specific exercise. So if they're happy to do exercises as part of that, that's just brilliant. But if you have somebody that's absolutely not motivated to do any kind of exercise, but are happy to go for a walk, then start there.
Yeah, I would fully second that, and I think it's really, really important that we're mindful of, or probably rather, what we consider to be exercise, because it pretty much depends on what is the current status of the patient. For some patients it may be a significant undertaking just to empty the dishwasher. So that could be the exercise of the day, or break it into components. So you would do activities that mimic what you want to achieve. Because very often people would have a dislike towards exercise as it's commonly known, like gym-based, heavy sort of, squats, deadlifts, or getting the yoga mat, from underneath the sofa and doing 3 sets of 10 or something along those lines. But being very broad in terms of what we define as exercise, and probably more saying activities that are meaningful to the patient. So if picking up your grandchildren is a problem, how can you design a training and exercise program that would break it into components? And this could be, for example, as little as standing up from a chair. That's an exercise for some people, and then just leave it at that. You don't need 80 kilos on your shoulders in a weightlifting room to have success.
It is not always about increasing performance and
No.
adhering to long-term training regimes, etc.
Yeah.
And that's also a common thing. Like many of the patients will ask, so what kind of equipment do I need to buy? And for the vast majority, you don't need anything.
They don't need. Yeah.
If they want to, there's some daily activities in their house that they need to do that they can't. Then they have all the things there they actually need. If they want to go to the gym, that's just awesome. But they don't need to if they don't want to. So let's try and modify and make it personalized to the individual.
Very good. So I think time is up. Let me say a couple of things. First of all, thank you very much, Stefan and Thorvaldur, for your time. I know that this is very, very late in Denmark, In Spain, we haven't even sit on the table to have dinner, but in Denmark, I know it's very, very late for being at work. So thank you for taking the time.